Right. Yeah, so I'm Alec. I'm one of the second years. If you don't know me, the plan today, I want to talk a little bit about upper GI bleeds, but being a small talk, specifically focus on the use of proton pump inhibitors in the emergency room when we have patients with severe upper GI bleeds. So the goals of today are to answer three questions. The first, do PPIs prior to endoscopy in the emergency room save lives? The second, do they change outcomes? Probably kind of answers that first question for you, so I apologize for spoiling that. And then the third is what medications do save lives or at least change outcomes when we have these patients with massive GI bleeds in the emergency room. So first, why might PPIs make a difference? Well, it comes down to two things. First, the majority of, or about 50% of upper GI bleeds are because of peptic ulcers. And looking at in vitro studies, blood usually does a better job clotting when the pH is over 6. So theoretically, the PPI, which should reduce the acidity of the stomach, increase the pH, should help blood clot and help stop the bleed in the patient with bleeding peptic ulcer. There is some evidence for this. There was a Cochrane review in 2004 in which they looked specifically at patients who were getting PPIs for patients with peptic ulcer disease that was diagnosed by endoscopy that were bleeding. And what they showed was that the PPI could reduce rebleeding rates and surgical intervention rates. They did not, however, have any impact on mortality. The important thing to note, though, is that that study does not apply to us in the emergency room. Those are patients that had already gone for endoscopy, had already had a diagnosis of a peptic ulcer disease, and were known to be bleeding from that. For us in the emergency room, as we showed, almost half of our patients are going to have bleeding for some other reasons. So the question is there any benefit in giving that PPI for us in the ED? Thankfully, there was a second Cochrane review that was done in 2010 that asked that specific question. Do PPIs prior to endoscopy have any impact on patients? They looked at 6 different studies. They pooled together about 1,000 patients that mostly came from double-blinded randomized controls, so not all were double-blinded. And what they showed, first and foremost, was that there was no evidence that initiation of PPI treatment prior to endoscopy had any impact on mortality for patients with undifferentiated upper GI bleeds in the emergency room. Not surprising, given that they didn't impact mortality for patients that we already know have peptic ulcer disease and have the best chance of having impact from the PPIs. So to answer that first question of do PPIs save lives, the answer to that seems pretty clearly no. So do they change outcomes? The Cochrane review looked at several patient-related outcomes to try and answer that question. The first that they looked at were rates of rebleeding. Obviously, this would be something that's patient-oriented. If the patient starts bleeding again, needs another endoscopy, needs another procedure, that could change outcomes. Unfortunately, they showed that PPIs did not have any impact on rebleeding. Similarly, they showed that PPIs given in the emergency room did not have any impact on the need for surgery in these patients. So because of that, the Cochrane review and the number needed to treat researchers concluded that proton pump inhibitors really have no patient-related benefit when given in the emergency room for an upper GI bleed. So do they really do anything when we give them? That question seems to be a little bit murky. There may be some more disease-oriented outcomes that PPIs might impact when given in the emergency room. Specifically, what the Cochrane review looked at was what they kind of pulled together as stigmata of recent hemorrhage. So what that means is that when these patients finally went up to get the endoscopy and they looked in, the question they were asking is, how bad does that bleed look? Is there evidence that it was just recently bleeding, that it's still trickling, that there's a clot there that seems potentially unstable? They said there was some statistically significant evidence that PPIs given in the emergency room could potentially reduce that stigmata of hemorrhage. However, they noted that in their meta-analysis, this was very statistically fragile. And if you remove just one of the trials that really dominated these results, that statistical significance would go away. Furthermore, they made kind of an interesting comment about this study specifically, which is one of the ones that they included from 2007. So what this study suggested is they looked at that evidence of recent stigmata when giving the PPI. And what they showed was that because that was lower, they were able to reduce endoscopic hemostasis by about 14%. So what they said was that when the PPI was given, when they actually were already in there looking to see if there was any bleeding, they had to do something as far as endoscopically, about 14% less of the time. However, the Cochrane review editors point out that what they saw in those patients where they didn't do anything, the patients that had gotten the PPIs and they didn't do anything, about 6 of 120 of those patients ended up having rebleeding and having to go back for endoscopy, whereas none of the patients in the placebo group had to do that. Importantly, though, because this is a talk trying to focus on evidence, this was not statistically significant. So I don't think we can really run too far with those results, but it's just something interesting to be aware of that they do point out in the Cochrane review. That being said, I think it doesn't really matter because we can say for us, whether or not, I think realistically, whether or not when they're already doing that endoscopy, they end up doing some kind of intervention in that endoscopy, probably doesn't really impact the patient's outcomes. So for us, I think we can safely say that PPIs, when given in the emergency room, are not going to have any real patient-oriented outcome or benefit. So perhaps this question then, if we say that, is kind of null and not a really valid or important question if we're saying it doesn't really matter in the first place. But it is probably worth being aware of this study, just for if you're pushed to give a PPI by GI. There was a study done fairly recently that looked at, after endoscopy, whether there was a difference in outcomes from giving that boluses intermittently of PPIs versus giving a bolus and then starting a drip. And what they said is that there was really no impact. So at the very least, if you're being pushed to give this, you can at least just give the bolus and not tie up a line with trying to do a PPI drip. Because even when we know it's a bleeding ulcer after endoscopy, it's not going to make a difference. So how do we save lives, or how do we change outcomes in these patients? So what I wanted to do here was just go through some of the other medications that we can think about giving in the resuscitation bay when we see these patients, and just quickly go through some of the evidence for it. This is not meant to be a deep dive in this evidence, so I'm happy if anyone during the, afterwards wants to bring up any other points or anything that they've read. But really the goal of this is to kind of show what the main thinking or the majority of the evidence shows and get you thinking about whether or not these medications are actually useful. So how about TXA? TXA is something that I think we, in emergency, are getting very excited about, trying to use it for everything. Theoretically, it could potentially increase clotting and would potentially have an outcome on reducing the mortality from these GI bleeds. Unfortunately, the HALT-IT trial, which just came out, showed that there was no decrease in death due to bleeding secondary to TXA when given for GI bleeds. And so I think we can say that TXA right now does not seem to work for these GI bleeds and shouldn't be the priority of what we try and give them. How about octreotide? So octreotide potentially could have benefit if you think that the patient has a GI bleed from an esophageal varices. Theoretically, it should reduce the portal venous pressure, which could potentially reduce the amount of blood going through the varices and allow that varices to stop bleeding sooner. The evidence for this, though, also does not show that this has any real mortality benefit or any reduction in rebleeding. The reviews that looked at this did show there was maybe some reduction in the units of blood transfused, but it was a very small amount and probably did not really impact patients. So I think we can say that octreotide as well should not be the thing you're focusing on during the resuscitation of these patients. How about this, which I'm sure we all recognize as erythromycin? It's a question about whether or not erythromycin would be important for patients with these GI bleeds. Point being, erythromycin, the reason it could potentially work is not as its impact as an antibiotic, but as its impact on an actual pro-motility agent. What erythromycin can do is help clean out the stomach so that when they do the endoscopy, they have a little bit better view of it. Kind of like a colonoscopy prep, but for the upper endoscopy. What they showed was there was no mortality benefit, but when given prior to endoscopy, they had better visualization of the gastric mucosa, and about 1 out of 9 patients that got it didn't need to go back for a repeat endoscopy. So you're not going to save lives with this medication, but it could potentially have some patient-related outcome where they don't need to get repeat scopes. So I think for that reason, it's something that we could think about potentially giving in these patients. How about ceftriaxone, or just in general, antibiotics? So antibiotics in patients that have cirrhosis and an upper GI bleed are going to save lives. So if you give 22 of those patients antibiotics, you're going to be able to save 1 life. If you give 4 of them antibiotics, you can prevent at least 1 infection. So for patients with cirrhosis and upper GI bleeds, antibiotics are something that we should be prioritizing during that resuscitation. So blood, I think that one's kind of straightforward. If the patient is actively unstable because of their bleeding, blood is going to be important. I didn't see any randomized control trial where they decided not to give these patients blood. But there is some evidence that I think is important for us to be aware of, though it doesn't actually apply to the patients that we're talking about here that are unstable in the emergency room with a GI bleed. But I think it's something that you might hear about, so I wanted to just quickly highlight this study. This was a study that looked specifically at what the transfusion goal should be for patients with upper GI bleeds, and it compared 7 to 9 as far as their hemoglobin. And what they showed is that the patients that had the more conservative transfusion strategy, or I guess the patients that had the goal of 7, had better outcomes. However, the reason this doesn't apply to us is that these were for patients that were already up in the ICU, and they specifically excluded massive upper GI bleeds. So for those patients in the emergency room that are unstable, you're not going to wait for their hemoglobin to come back and decide, oh, it's 7.1, so we don't need to give them blood. Reversal agents, this is a much bigger conversation, I think, than what we have time to do here, but it's something that we need to think about when we're resuscitating these patients. It's going to be very patient specific. It's going to depend on how unstable they are and why they're on their reversal agent. Might be different if they're on Eliquis because they have AFib versus if they're on some other Coumadin because they have a prosthetic valve. But if the patient's actively bleeding out and they're unstable, you should probably be considering and most likely giving something to reverse their anticoagulation if they're on it. In a similar vein, one thing I wanted to just bring up was the question about DDAVP in patients with liver failure that are bleeding, or essentially in patients that are uremic and bleeding. Uremia can cause platelet dysfunction, and there is some evidence that giving DDAVP can actually reduce bleeding time for just in general for patients that are bleeding secondary to uremia. I wasn't able to see any studies, so if anyone's aware of them, please let me know, that actually looked at this question for giving DDAVP or not giving DDAVP in patients with GI bleeds. But there does seem to be some evidence just as far as in general that it might be worth considering to try and reduce the bleeding time for those patients. So most importantly, the question is, how do we apply this information in the emergency room? When you have the patient that's coming in, unstable, the massive upper GI bleed, what do we do with all this information? And I think that main takeaway that I want to have from this talk is that we should think about the things that are actually going to make a difference and actually save lives and improve outcomes. When you have this patient, it can be a chaotic room. They're just scary patient to approach. And I think because of that, we can get caught up in all of these other things that we want to think about giving. So if you have this patient, just remember the things that are actually going to make a difference are blood. You could antibiotics if they're cirrhotic. You could consider giving the erythromycin before they go up for the endoscopy. And you should think about reversal agents. The thing that you don't really need to worry about are when or how you're giving the PPIs, because they're really not going to make a difference. So I just want to say thank you to the Small Talk team, Dr. Turner, Dr. Chu, Dr. Kopchak, and I'm happy to answer any questions if you all have them.
Did they do any studies on FSID?
Yeah, I think so. Yeah, I believe it doesn't make a difference, but yeah. Yeah. Cool.
These patients can be really sick. We see a lot of patients with GI bleeds, and they're fine. The person in front of me has very strong opinions on it, but I think the most important thing is really blood. I think we very often under-resuscitate these patients, and it puts them at risk. And so you have to really have a low threshold to be aggressive with resuscitation. Do not be afraid of treating these patients like major trauma patients. Put in a cordis, hook them up to level 1. Occasionally that will save their lives. And the other thing to remember is the answer for most of these patients is not endoscopy. Endoscopy does not change their lives. Our resuscitation in the emergency department changes their lives. Endoscopy is for later. because if they're actively hemorrhaging, the only time endoscopy is really gonna make a difference is if it's a variceal bleed. But if it's a non-variceal bleed, the endoscopy is later. There's nobody who needs an immersion endoscopy unless it's for varices. So you need to resuscitate that patient. Once they're stable, then they can go do an endoscopy, hopefully find the site of bleeding and then do their intervention. But the most important thing is the resuscitation that we do for those patients. Calling GI and telling them that they have to come and do the endoscopy is not going to make a difference for that patient. Because these tend to stop at some point. If they're gonna survive, they're gonna stop on their own and then they can get their endoscopy. But you gotta resuscitate them.
Such a small window between them being too stable and too sick for GI to scope them. So I agree with Dr. Schechter, and I always hear Dr. Denny talking to me about this. No one's coming to save you, you just have to resuscitate the patient. Something I've learned, intubating them early is helpful as well, especially with the upper GI bleed. I've started pulling the trigger much earlier on these patients, so do this more. That's something that I just kind of I've learned, and then, just resuscitate them like they're a sick population.
Definitely gets into the ICU.
Well, that's true.
Alex, go back to slider, please. Yeah, that one. I just want you to remember that picture. It's very triggering. Like the red snake coming out is never a good sign. These guys, when you paralyze them and go to intubate them, you open their upper esophageal sphincter and just blood just comes pouring out. So be prepared for it. Have suction ready. If you want to do that maneuver where you put the suction down into the esophagus while you're intubating, I think that's a great idea. But just be prepared. If you're going to intubate these guys, that's what it's going to look like. And it's going to scare the crap out of you. And put it
Thank you, Alex.
I have a question for these patients, like for the attendees. Would you guys recommend trying to do like an awake intubation with like ketamine or something, so that, or has anyone tried that? I don't know.
I would not.
No.
I think all the evidence, I don't know if they can hear us, all the evidence shows that your best first pass attempt, your highest likelihood of success is to do RSI.
Including with paralytics.
Yeah, I mean, RSI, not awake intubation, RSI.
Summarize the answer seems to be no, if you didn't hear that.
One of the things that I say to the nurses when these patients come out, so that you like 5 minute break or two and have it at bedside, just be aware also how it works, and in case that the patient might start pouring blood, just go ahead and do it. Something also.
Yeah.
Thank you, Alex.
Yeah, thanks.